Our next session is titled Building Your Dream Team, Preparing for the Road Ahead. Our chair, Dr. Kumthekar, will discuss how to prepare yourself mentally and logistically for your treatment of CNS metastases, including who to have on your team and what roles does each team member play. Please welcome Dr. Kumthekar.
Thank you so much, Emily. It's so great to be here. And as I mentioned previously, the goal of today is really to kind of simplify the complexity in your care. So there's so many different doctors involved in brain metastatic care, and there's so many different treatments. And so I'll just run through these slides and with the goal in mind of just simplifying this complex web. Right, here are my disclosures. So medical care as a whole, of course, can be complex, and brain metastases is no exception to this. There are many doctors, many care teams involved really in the care of brain metastases patients. So we want to really look at this and see not only who is that team comprised of, but how do you navigate that world of multiple doctors? Who should you go to for what issues, and how should you define that? So we'll go over these questions, like who are my care team? What role do they play? What can I expect? And then I'm going to save plenty of time for some Q&A as well. So for starters, the who is on my team. So it is there's the primary, the systemic oncologist. So for those of you who answered the poll earlier, those are the breast oncologist, thoracic oncologist, or general medical oncologist, depending on where you're receiving your care. There's also the neuro-oncologist, so the medical neuro-oncologist. So these are physicians like myself who are basically oncologists specifically for the brain setting. So we are doctors who prescribe medications, so chemotherapies and so forth, for brain-specific disease. There might also be a neurosurgeon involved. That neurosurgeon might be a part of the picture because of brain resection, so tumor resection, or because of other implantations. So let's say a VP shunt or a ventriculoperitoneal shunt, or a port placement in the brain called an Ommaya port. So there's neurosurgeons can be involved in many different ways. And radiation oncologists are also quite central in the care of brain metastases patients, as radiation remains a mainstay in treatment. Palliative care, and you'll also hear from a neuro-oncology palliative care specialist later today. Palliative care often gets synonymized with hospice care, but they're really quite different in the sense that palliative care, as we'll get into later, is really just a focus on quality of life and symptom management that should be existing throughout the course of its needs. So throughout the course potentially of your entire treatment, and at least during the part of your course where you're heavily symptomatic. And then we also lean heavily on therapy services, and this is anchored by our physical medicine and rehabilitation doctors, or PM&R doctors. They're also known as physiatrists. There's also, of course, physical therapy, occupational therapy, and speech therapy. And when we think about this team, you lie squarely in the center of this team. So everything, I tell my patients, it's team Bob or team Sue or whomever, but you're the center of that team, and we're your care team around it. And unlike primary brain tumors, for metastatic brain tumors, how I define this to my patients is the primary oncologist, so whoever that is, be it your breast oncologist, thoracic oncologist, general oncologist, is really the quarterback of that care. So it's team you, run by that, as the whole heart of the team, and the owner really of that team, but that team is quarterbacked by your oncologist. So all the decisions that I make as a neuro-oncologist for my brain metastases patients gets ultimately run through and approved by that primary oncologist. So that's the dynamic that is present, I would say, at most places. And then all these services run around it, right? So these are people working as a team, communicating together about your care. in many different ways. So that can be in the format of things like tumor board. It can be in the format of things like emails. For example, I had clinic on Wednesday, saw multiple brain metastases patients, and sent out multiple emails with all of these players on board on CC, where we're discussing specific issues and discussing them jointly together. So what are the different variables to this? So I've kind of given you an overview on how team U is made and your dream team. But what are the different things that might modify or change that team? Well, the first thing is institutional variables. So for example, your institution might not have a specific neuro-oncologist or a physiatry team, or, insert whatever specialist. So that there is a variable there in terms of how that can work. Additionally, you might have a neuro-oncologist who doesn't prescribe chemotherapy, so that might introduce variability. There's also variability introduced with second opinions and shared care. This is great when I say there's, whenever we share care with somebody from another institution, I always say, we're all on that same team, because it goes back to that model of, spoke and hub, and you're in that center as that hub, regardless of what institutions you are receiving care from. So that should all sort of work fluidly, of course, within reason, right? We don't want to have 100 executive chefs in the kitchen or 100 chefs in the kitchen, but within reason, these should all also act as that center with you at the center. There's also specific procedures and treatments that at times might lead to specific physicians then kind of quarterbacking at that moment. So for example, if you're planned to have surgery later this week, typically that sort of quarterback services is handed off then to the neurosurgeon for those few days where those decisions are run through that neurosurgeon with the pending procedure. Similarly with radiation, so things like stereotactic radiosurgery or whole brain radiation. If you or your loved one is going through those therapies in that moment, in that clinical scenario, that physician might be kind of taking the ball and taking the lead. And similarly with intrathecal therapies that we deliver within the neuro-oncology clinic. So for those of you guys who are unfamiliar, this is therapy that we deliver directly to the fluid that surrounds the brain and the spinal cord, called cerebrospinal fluid. So you really need to kind of think about these specific procedures and treatments and who we turn to for each one, and who's leading each of these decisions and treatments. So I think it's important when you don't know who's doing what and who's making what decisions to take a moment to sort of define the relationship. As cheesy as that sounds, I think it's okay to say, to clarify expectations. Who should I call for my change in symptoms? Who will be prescribing my treatment? Who should I call for medication questions? These few questions might be different depending on which treatment and which medication we're talking about. For example, if I share care with a breast oncologist for one of my patients with breast cancer and brain metastases, the chemotherapy might be run through that breast oncologist. But if I'm prescribing, let's say, the steroids and the seizure medications as the neuro-oncologist, those questions might be run through me. So it's very complicated, but I think if you just take a few extra moments to have these conversations, it's very reasonable to ask these questions to your care team, be it the nurse in the care team, the doctor. Who should I call for this? Shall I call you for this? Who should I communicate with over my chart, let's say, for example? And I think it's also important to say who will be ordering my neuroimaging or who will be ordering my body imaging. So for example, I typically tend to order the brain or the spine imaging as needed for each of the patients that I see. And then I leave the ordering of, let's say, the body imaging with the CT chest, abdomen, pelvis, or a PET CT or a bone scan. I leave that to the providing oncologist. So these are conversations that we have on the back end as well, but that you should be aware of kind of what that separation of responsibilities is. And very similarly, who will be following my neuroimaging? So when I do get my brain scan, who do I see after? Do I see my neuro-oncologist? Do I see my radiation oncologist? Do I see both? I can tell you that this is something that has a lot of variables to it. Oftentimes, when my patients are doing well and they're just getting, let's say, every 3-month brain MRIs, they often are just seeing me alone at each of those every 3-month visits. And if something changes on it, then I bring in the radiation oncologist, the neurosurgeon if needed. And then always through the background of this, you're always following your systemic oncologist as that quarterback of your care. All right, so what else am I forgetting to ask in terms of from your perspective? So I will say, when you are not sure, just in the kindest way, confirm that there will be communication between your team. So if you are seeing your neuro-oncologist, for example, it's very reasonable to say, can I expect this information to be conveyed to my insert doctor name? So to my oncologist, to my radiation oncologist, to my care team, defining who that is. The answer is probably a yes, but I think that it could give you comfort to know that everyone is tied together. I typically kind of set that expectation from the beginning with my brain metastases patients so that they don't have to ask that question or have to ask that question in the future. I kind of let them know a priori, listen, every time I see you, I'm going to be touching base with your oncologist, letting them know what your scan looks like, letting them know our plan, just to kind of give that peace of mind that your whole care team is working together. And then this is really important because it's also very variable, not just on institution, but on the specific physician, which is determine the best mode of communication and who to communicate with. So is that best mode of communication my chart? Is it phone calls? Is it with the whole care team? Is it with the nurse? And kind of who do I communicate with for what? Taking a couple extra minutes to do this, at least at the initiation of that relationship, can be very, very helpful for you and your care in the future. And then just know that this brain mets machinery of all of these different docs working together, we're just at the end of the day humans, right? So the machinery looks different, hospital to hospital, and actually doctor to doctor. So kind of understanding what that looks like where you're receiving your care is really important. So what can you expect? Well, you can expect that if you've been diagnosed with the brain metastases or any CNS metastases, that you're going to get neuroimaging for life. That frequency could be different year to year, but generally speaking, we'll always continue to watch you closely and you'll always have brain surveillance so that we keep you safe, or as safe as possible. And yes, brain metastases statistically tend to recur. So you can expect further management at whatever time that we might see that at. We, of course, hope that that's not the case, but we want to walk in with expectations so that you don't have surprises in the future. Those treatments in the future can be very different depending on circumstances. So it's really hard to prospectively in advance plan what that plan B is going to look like, whether it's medical therapy, radiation, surgery, so forth. What I tell my patients is we're going to have a plan B. And that plan B cannot be really defined now because of these different variables that we're waiting on. It's the other analogy that I give is that it's like a chess match. I can't tell you what my next move is going to be without knowing what the next move of your tumor is going to be. So that's kind of important to keep in mind. So the decisions you can expect will be made by your full care team, but you'll have that designated quarterback, which typically is going to be your primary oncologist. All right. So I want to thank you guys for listening to this and definitely open for any questions that you guys might have. Oops.
Thank you so much. Just as a reminder, if you do have questions that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer questions as time allows. All right, so one of the first questions we have here is asking about an analogy that you made. You had talked about how the brain tumor machine can be different at different institutions. Can you describe to our audience what you mean by brain tumor machine or
Yes, and
brain
I
mets
don't.
machine?
No, absolutely. I just saw that question as well. So I don't mean a machine, actually. I just mean that exactly as you said, it's an analogy for that whole complex system that works together. So the machine of your whole care team. So I likely at the center, of course, is you, but in terms of the center of your care team is going to be your systemic oncologist and all your other care team providers. So neuro-oncology, neurosurgery, radiation oncology, rehab services. You might have other services involved like neuro-ophthalmology, endocrine. There's actually other pieces that I didn't put in there that could be all a part of that machine that takes care of you, the machine, quote unquote. So sorry if that was confusing.
Thank you so much for providing that clarification. Another question we have goes back to communication. You really emphasize the importance of having a team that is communicating with one another. Can you share what or how a patient can advocate for their team to communicate, especially if they're finding that there is a lack of communication between their team members?
Yeah, I think ask is probably answers 1, 2, and 3. Can you please send this information? Can you please send your note to so and so? And then I think that there might be moments where you take that communication in your own hands, right? I think at the end of the day, again, your providers, your physician providers have different styles of communication. And so there might be times where you say, you know, I'll communicate this to my that might happen. I think that that's going to be more exceptional. I think that you'll find that if you ask for that communication, that it should occur. And it likely would occur even if you didn't ask for it. But if you want to clarify, you can say that. And I think providing information. So if you have the phone number, the email, the contact, whatever it is of that provider, particularly if they're outside the institution, that's going to make it that much easier. So can you make sure that, my note is faxed to so and so, and that can be asked not just of your physician but of the nurse, or you can ask the medical assistant even that. So there's different ways to maneuver that if you're finding that's difficult.
Thank you so much for sharing that wonderful advice. Another question we have here goes back to that circle that you shared with the patient at the center and all these different providers. Can you share, where does a patient's primary care physician fit into all of this? Are they being included in these conversations? Are records being sent to them? Should patients be asking for that?
Yeah, absolutely. Actually, what a great question. And quite frankly, an oversight for me to not put that in there, right? Because there's variability in terms of the involvement of the primary care doctor. What I found is that in the course of cancer care for my patients, their primary care doctors, there's some variability in how involved they are. So the ones that are really centrally involved, we communicate everything to. And that usually is a question that I ask my patients early on. Often what happens is in cancer care, patients end up seeing their primary oncologist much more than their primary care doctor. And inadvertently, that primary oncologist sort of becomes your primary care doctor. And so that ends up being something that it's not that we don't communicate with them, but oftentimes it's in the kind of a format of just to keep you updated, here's my last note, and this is what's happening with, patient X, as opposed to, do you agree with this chemotherapy? Because usually primary care physicians aren't intricately involved in those decision-making processes. So I think it's that fine line between keeping them updated and whether or not they're integrally part of the decision making. There are certainly situations where they're very involved. So for example, if I have a patient with, let's say, a chronic disease from something else, let's say diabetes or liver disease, and we're wondering about the impacts of drug X to that, we might really heavily need the primary care doctor in that scenario. Or if a patient develops a blood clot that we're following, let's say with imaging or with medications, we often leave the primary care doc in that. So I think the short answer is they're absolutely involved, and the extent of which sort of is dependent on the scenario.
Thank you so much. A follow-up question to that. Some patients may receive their primary care at a different institution and their cancer care at another hospital or institution. Can you share how the communication works in a situation like that, where your teams may be divided or in different places?
The short answer is it works, right? It doesn't matter. I think institutions have walls, but not people. So I never find it difficult to communicate with anyone just because they're outside the institution. Now, the mode of communication, whether it's email, whether it's my cell, whether it's, through, even Epic, might be dependent on who that primary care doc is and what their preference is, but their communication should be happening, period.
Great, thank you. Now, in your slides, you also talked about second opinions, which are very important. Can you share just the process of receiving a second opinion? How can a patient find a different institution to get that from? Are you having your information from the place of your diagnosis sent over to them? Do they have to have additional biopsies done? What does that process look like?
Yeah, so it can look different depending on what you're looking for. So I, at least for my patients, always encourage second opinions. I think that they can be very therapeutic, just to know, if there's any other options out there. Or also, I think equally importantly, or maybe more important, is just knowing that you're getting the right care, or kind of feeling that comfort of, okay, multiple doctors are sort of saying the same thing. And I think it's very reasonable to ask your doctor, hey, I really appreciate all the care that you're giving, and I didn't think, just for my peace of mind, I'd like to seek a second opinion. And so, hold on one second. So you might say, hey, do you have any suggestions on who that might be? I'd really love somebody that you like and respect, or, I think that goes a really long ways. There's also a lot of different, there's endless ways to find, hold on. I'm so sorry. So basically, there are endless ways to find where to get second opinions, right? There's groups online, there's social media. There's just so many different ways. So I think that's probably above and beyond the scope of today. And then in terms of medical records for that, you get medical records typically from medical records, but it depends on where you're going. So for example, when we receive second opinions, patients for second opinions, our intake coordinators have a process by which they request those outside records. And so every system might work differently. You're going to need to ask. So wherever you are going for your second opinion, you ask them, will you be requesting these? Shall I bring them? And my recommendation for everyone, especially for imaging, is to bring your own imaging on disk, even if they've requested it, because that often doesn't end up getting transferred properly. And without your imaging, it's rendering that second opinion less effective. So you want to sort of take things in your own hands. And I would say one thing to not do is, after let's say you ask your doctor for who you might go to for a second opinion, don't then ask your doctor for a stack of records. They are not themselves medical records department. So we don't have the ability to take Epic and burn a disk for you. We don't have the ability to print out hundreds of pages of records. That's a task really of your medical records department within there. And then in terms of what specifically is asked for after that review and after that consultation, that's going to be dependent on your specific clinical scenario. I'll say one last thing on this. Second opinions can be really good, but when you start to turn into third, fourth, fifth, sixth opinions, they can sometimes be overwhelming and mind-boggling, and kind of gets to the point where it might not be helpful because it'll give you whiplash. So, I encourage second opinions, but a collection of opinions can sometimes delay care and confuse you more. So just kind of keep a balance of those second opinions.
Thank you so much for that very important insight and advice. We have a question here from a patient asking, should all brain mets patients have a neuro-oncologist? This patient, just to share a little more, has non-small cell lung cancer as their primary with brain mets, and has a neurosurgeon, a radiation oncologist, primary oncologist, but not a neuro-oncologist. Is this normal? Do you see this often?
Yeah, I mean, I think that's a very patient-specific question to ask, and one that I don't feel fully comfortable just answering as a simple yes or no. I think if there's complexities to care, it's really nice to have a subspecialist like a neuro-oncologist. It's also not fair for me to answer because I'm biased as a neuro-oncologist, and I do think that there's value that can be added. But then the opposite question is something missing from your care because you don't have one? And I would have to know all the details of your clinical care to know that, but there are many scenarios where that answer is no. If you have really great docs taking care of you, there are many great cancer centers in the US that don't have close neuro-oncologists. Unfortunately, we're a very small field, so there's not a plethora of them everywhere. I think of the greater Chicagoland area of 10 million people, and there's something, like 10 neuro-oncologists, right, for that big of a population. So you might not have one everywhere, and it does not mean that your care is substandard by any means.
Thank you so much. I think we have time for just one more question. In this creating your care team, right? A piece of that is also your care partner, your loved one that's going through this with you. Can you share where do they fit into this equation that you've kind of built out, and how can the care partner and the patient work together with the care team to ensure that their loved one is getting the right care, they're making the decisions that they need to?
Yeah, I mean, I actually consider that person or people at the center with that, where I wrote you, right? And to me, they're implied in that you. It's sort of that collective you of you and everything that comes with you. So you, your loved ones, your kids, your care partners, your jobs, your activities, your quality of life, all of that really fits in that center spoke of you. So where do they fit in terms of your doctors? Well, they're part of the conversation as well. What I would say is streamline that communication. So I usually ask, who's the person that, we need to be communicating XYZ to, and make sure that you on your part are doing your communication. So for example, I had a patient this week who at the appointment had her care partner present, but then afterwards separately asked me to call her brother in California, call her sister, like 3 different family members that were each like long conversations, but I it did it, but I kind of set expectations that I need that person to streamline, like you being at the center of that spoke. The reason I don't list all the people in your life is because that looks different for each person. And just as your oncology team manages the communication on those spokes around, we do rely upon the patient and the patient's care partner to manage that communication within your team at that center. So that's the one expectation that we have in turn of that care team. So if that means instead of your doctor making 8 different phone calls, conferencing them in, that's no problem, right? So as much as we talked today and focused on streamlining communication on the medical side, make sure that you don't lose the message of communicating and streamlined communication on the patient side as well.
Thank you so much. That is all the time that we have for questions. I'm going to turn it back to Emily for the rest of the program.